let's morph this a little bit and talk about then who's at risk. We've already talked about patients who come back with recrudescent C. diff. So there is an increased rate, I think it's safe to say, in community onset, not necessarily community acquired C. diff. What's that due to? Where do we go with that, Dr. Brandt?
Well, the community probably represents up to maybe 40% of the infections that we see. I think that that's a reasonable number, although studies vary on this from lower number to about 40%. And what's interesting about the community cases is that they're occurring in a group of people that heretofore were not recognized to be at risk of this disease. We'll come to risks a little bit later in this discussion, I'm sure, and we'll talk about the older person and the sick person. But in the community, we're seeing maybe half of the people who are not on any antibiotics at all. And they're younger, they're not older. So it's a little bit in contrast to the traditional approach to this disease.
Well, you know, the mantra was, when I was learning about C. diff, that, okay, it happens in the community, and these are people who get broad-spectrum antibiotics for a long time, and now they have C. diff, and you're telling me it's not associated all the time with antibiotic therapy.
That's correct. It is not associated all the time.
But we do have to understand that community-associated, community-acquired C. diff is not very well defined, and there is a difference between C. diff happening in the community versus C. diff that happens in someone who didn't have any exposure to healthcare. And this is really important. And if you actually look at C. diff that happens in a community, there are three big groups. One are those people who just got discharged from nursing homes and hospitals as well.
So not healthcare naive.
So they're not healthcare naive. And in fact, if you look at the healthcare naive, the recent data suggests that about 80% of them had some sort of exposure to healthcare within the 12 weeks preceding the occurrence of their disease. To what extent does that contribute to their infection is not clear.
Well, I think that also comments on the patients themselves. These are people who, because they're going to dialysis, because they have chronic comorbid medical conditions, are seeing the doctors frequently. So the underlying substrate is just imperfect, and they have a lot of interfaces with the healthcare system.
And what about people who have C. diff relatives, that if they're in the hospital, they've had C. diff, they go visit, is that considered, and then they go home and they get sick, is that considered community acquired or hospital related? It's an important definition, isn't it?
I don't think that people, yes it is, but I don't think that people distinguish between those in the classification systems. And it's a very important concept.
And last, out in the community, again, we're not talking about the people with multiple comorbidities in an ICU, but people that you point out simply pick up C. diff and present with C. diff. As a group, over time, is this group getting sicker as a group, as a cohort, or is this community-acquired disease sort of the same over time?
I think it's still the same, and it's generally much milder disease in the community. But the big difference today is that when I started in C. diff, 90% of all cases were diagnosed in the hospital. And then the length of stay was 10 days or 14 days. Now the length of stay is 4 days, and I think what we're seeing is procedures being done in ambulatory patients now that were done in the hospital previously. And many of these community cases, 80% in fact, have got some kind of ambulatory healthcare contact.
So they would otherwise previously have been in the hospital, but we've discharged them earlier, and the C. diff is the same.
And two things happen to you when you're seen by healthcare providers. Number one, you get exposed to antibiotics, more likely, and number two, healthcare environments are contaminated with spores of C. diff, so you have kind of a double whammy. But the big mystery, though, is, as Larry points out, many ambulatory patients who get C. diff do not have a bona fide antibiotic exposure.
And do you think that the disease is more mild because the disease is more mild, or it's because the person that it occurs in is actually healthier?
I think it's because the people it occurs in are healthier. That's not a uniformly common statement, but because there are elderly people in the community who do get it.
Yes,
no
there
question
are.
about it.
But I think, just to extend it, I think an important message is that when you see patients who develop C. diff in a community as a primary care physician, it doesn't mean that those people have community-acquired C. diff. Those could be people who were just discharged from the hospital, who have severe disease, who can have bad consequences of this disease. And in fact, a lot of the severe consequences of C. diff are seen in the community. It's not community-acquired C. diff, but it's still seen and diagnosed in the community.
All right, let's take a look at the C. diff itself, because everyone who hears C. diff thinks diarrhea, thinks sepsis, thinks potential perforation, thinks megacolon. But let's go back to first principles, if we can. In order to recognize this thing, we probably should know how it does what it does, right? And how C. diff affects the intestinal system at a very fundamental level. What's the problem with this bug?
Yeah, just in the last couple of years, we really started to learn about the pathophysiology of C. difficile infection. So part of it is, what are the important bacteria that protect us against C. diff? And just with more recent sequencing technologies and looking at stools and what bacteria are present, it actually looks like non-C. difficile Clostridial type species are very important at protecting us against C. diff, as well as Bacteroides type bacteria. And exactly why this is not clear, but one mechanism may be related to bile acid metabolism. So when you give antibiotics, you're altering the bacteria in the gut and then altering the secondary bile acid metabolism from a state that prevents C. diff germination proliferation to one that promotes C. diff germination proliferation.